channel. Today we will be given an overview of what the Enhanced Community Care Programme is and what it means for the counties of Cavan, Donegal, Leitrim, Sligo and Monaghan and associated hospital groups. As the ECC is designed to shift care from acute to community settings, this webinar is most relevant for staff working in community and acute settings in these areas. So before we start, just a few housekeeping points to note for today's webinar. Today's event is being recorded and this recording will be made available to view on the YouTube channel. If you have registered for the webinar using your email address, you will be sent a link to the recording once it has been added to the channel. Please note that the video will only record the panellists on screen and not the audience members or chat feed. For our audience attendees, you will note that your audio and video is turned off. This helps to assist us in managing the online event more smoothly. There will be a Q&A session at the end of this webinar. During the webinar, you can put your questions into the chat box for answering at the end. An FAQ document will be produced following today's session. As we may not have time today to address every query raised, we will be circulating that document in the coming week. If you do have any technical issues or questions during the event, please post a message to the host in the chat box in the bottom right and we will do our best to respond to your comment or query. So without further delay, I will now commence formally this afternoon's session. So as I said, you're all very welcome today and it's great to see so many people registered. There were over 200 registered for this webinar and we look forward to supporting you over the coming months and years as we work together on the significant and exciting healthcare transformation programme that is ECC. The ECC programme is part of the Sláinte Care reform, delivering the right care in the right place at the right time with real investment in community services, resulting in over 380 new posts for our area. The programme includes three components initially. Implementation of the community healthcare networks, which there are 8 across our area, and some of those boundaries have been realigned. Establishing community-based integrated specialist team for chronic disease management, initially diabetes, respiratory and cardiology, working very closely with GPs and acute hospital colleagues. Establishing ambulatory care hubs for older persons to enable them to remain living in their own home and community. This includes care for frailty, falls prevention, dementia and complex case management, with an integrated frailty at the front door team based in the ED department in each of our 3 aligned acute hospitals. The programmes are designed to create equity of access for a population to those requiring low-level primary care, those who need specialist care for chronic conditions and conditions of old age, and who are not in need of hospitalisation. The programmes will meet the needs of patients within their communities and outside of acute settings, which will help reduce the demands on our acute hospital systems. These new teams and services will work together, connecting care pathways that step up from primary care centres to acute settings and back to the community, following the patient journey. There is also a focus on keeping our population well and improving quality of life through our Sláinte Care Healthy Communities programme, of which we have 3 sites across our area. These are led by our health and wellbeing team and includes tobacco cessation, healthy eating, positive parenting and social prescribing. I am really delighted to have recently taken up the post as GM for ECC, and I'm responsible for overseeing and coordinating the planning, implementation and reporting of this integrated programme, working really closely with our general managers in both acute and community and supporting senior managers across all settings. I'm currently establishing the GM ECC office team and we look forward to working with you and supporting you to successful delivery of the programme and therefore improve care of our service for our service users and our population. I would now like to introduce Dermot Monaghan, our new Chief Officer, and Mr. Tony Canavan, CEO of Sálinte Healthcare Group, who are the co-chairs of the CH Cavan, Donegal, Leitrim, Monaghan, Sligo Sales Integrated Forum, and Miss Anne-Marie O'Connor, who is the Director of Nursing for Integrated Services Cavan Monaghan, who is attending on behalf of Miss Suzanne O'Callaghan, who is the General Manager for Cavan Monaghan Hospitals. Dermot, I'll just hand over to you now. Thank you.
Thank you, Lynn. Thank you, Lynn, and welcome, colleagues, to this webinar, which I hope you find very, very useful. as Lynn has outlined earlier there is very clearly a significant investment going on across the community services and in our hospital services around enhanced community care, which is part of Sláinte Care Reform Programme. Our community healthcare area has a long history of collaboration between ourselves and the acute colleagues. We've worked very hard to make sure that we try to put the care in the right place for the right person at the right time. We've also been very productive in integration, and we've a number of Sláinte Care integration projects that we've been successful with, 11 of them, and they've all now been mainstreamed. This was before enhanced care was in place. As Lynn has outlined there, enhanced care, community care is three legs of a stool. One is the community healthcare networks. There's 8 of them across our area. We have 2. The second part is the chronic disease management hubs in Letterkenny, Sligo, and Cavan. And the third is the ICPOP teams that are attached to the chronic disease management hubs. A lot of work is done to date. One of the first things that we did, which was needed, was we set up a joint integrated governance framework, whereby myself and Tony chair a single oversight committee. We then have Frank Morrison and Sean Murphy, who jointly chair the Donegal ECC committee. Cara O'Neill and Grania McCann joint chair the Sligo Leitrim committee, and Mandy Doyle and Suzanne O'Callaghan do the Cavan Monaghan one. Lynn is a great asset, and our team are a very significant benefit for us, because they will provide a lot of support to us in making sure that we deliver on it. From the community perspective, we have 324 or 25 posts approved. There's a number of posts approved for each of the hospitals as well. And at the present moment, we're sitting at 78% recruitment. We've also got our facilities well developed. We have the Letterkenny Chronic Disease Management Hub already set up. So also in Sligo, and we're working on the Cavan Monaghan one at the present moment. So a lot done, more to do, but it's a great opportunity for us. It's a great investment programme. It's the first time that really significant investments have gone into primary care and to community services in general. So we're really looking forward to making sure that we use these resources to provide the best benefits to our clients and the people we serve. A lot of this is predisposed also on new ways of working, and part of the agenda for our area committees is to look at the pathways of how people access services at the present moment. What can we do to improve those pathways, and also to make sure that where services can be easily transferred out into the community, that is done. An example of that is the diagnostic services that are developing across the region, particularly strong in Donegal, but also new services for X-ray and ultrasound starting in Cavan Monaghan as well. So pretty good work done, and really want to thank all for putting their shoulder to the wheel, especially with COVID as well, and want to acknowledge the contribution of all our staff through COVID as well, and achieving what we've done through that COVID period is down totally to the managers and staff at the front end. So well done to everybody there. And then I'll hand over to Tony.
Very good. Thanks, Dermot. Thank you. And thanks to all the colleagues that have been involved in organising the webinar here this afternoon. I think it's a very good way of communicating what's happening. And similarly, I'd also like to thank colleagues on both the hospital and on the community side for the work and the effort that has gone in so far to developing the Enhanced Community Care Programme. And this is a work that's very much in progress and progressing very well. Just picking up on some of the points that Dermot has made, on the hospital side, we absolutely look at the Enhanced Community Care Programme as an opportunity. It's an opportunity for us to do something different, to start to deliver services in ways that we weren't able to do in the past, but ways that we always knew was important, bringing services close to where people live and work, providing care at the lowest level of complexity, helping people to live in their communities, supporting people to live in their communities or in their own homes for as long as is possible. And all of these are the kinds of principles on which the Enhanced Community Care Programme is based. So it's a real opportunity for all of us. And I guess for some of us that are maybe entering the final quarter of our working lives, it's maybe the last opportunity to make a really significant difference to the way that we structure our health services so that they deliver really good care to people that are living in our communities. Dermot has also referred to history, and I think history is important here because when you look across the Northwest in particular, and obviously because the SAIT group is looking after Sligo and Letterkenny amongst our 4 other hospitals, and that's the area that we're most interested in. There is a long and positive history of collaboration and joint working between the hospitals and community in the Northwest. And that's a really positive history, and it's a really positive foundation on which to build enhanced community care. And it's great to see that that people see value in that and that they're working on that basis. But there's also a more recent history, which Dermot actually has also referred to, of joint working that I think demonstrates how things can be done. And that's the way that we managed our way through the last 2 years of managing our way through the pandemic and pulling together, because in some cases there was no option except to work together to make things happen. But mainly because people saw it as actually the right way to deliver care and the best way for people to deliver care. And I do think, as we look back on it now, that I think that people working in the services look back on the two-year period of managing through COVID as actually a rewarding way of working and a rewarding way of delivering care in really very, very difficult circumstances. So history is important, and building on that positive history, I think will be important for the development of the enhanced community care programme. As Dermot also mentioned, this is also part of a broader reform programme within the health services, and we're likely to see, I think, a significant progress in that over the coming 12 months. The development of the regional health areas will be a very significant enabler for the enhanced community care programmes and will help to support that further as well. And while it's complex and it's difficult to be introducing such a significant change in the way that we structure ourselves and organise ourselves, I think we can all remain confident that these types of changes, rolling out of the ECC and developing the RHAs, that ultimately they will result in better care for patients and for people living in this part of the country. I do want to say that, that from our perspective, when we look at this as a real opportunity, an opportunity, as I said earlier on, to do something different. And our desire on the hospital side is really to stay in this for the long haul, to make sure that we make the most that we possibly can of this opportunity for people living in this side of the country. Thanks indeed, Lynn.
Thanks very much, Tony. And certainly the last couple of years have taught us a lot around integrated work, and as you said, have built on the relationships and strengthened between acute and community. There's certainly it's amazing what we've been through, and I'm sure we'll look back on it with great reflection in years to come. So thank you, Tony. Now I just ask Anne-Marie Campbell, who, as said earlier, is Director of Nursing Integrated Services in Cavan Monaghan, joining on behalf of Suzanne O'Callaghan to say a few words. Thank you, Anne-Marie.
Okay, thanks very much, Lynn, and thanks very much for inviting me on today. So as you said, my name is Anne-Marie Campbell, and I'm the Director of Nursing for Integrated Services in Cavan Monaghan, and directly employed by Cavan Monaghan Hospital Group. So I'm the representative for the hospital, and I work closely with all of the integrated services, including the operational leads in both Chronic Disease Hub and the ICPOP ambulatory hubs in Cavan Monaghan. And from our perspective, I suppose, in the acute service, we very much welcome the investment in our community services under the ECC programme and look forward to continually building relationships from both an in-reach and an outreach perspective to provide the best possible integrated services to our communities. As both Dermot and Tony mentioned earlier, there's a long history of collaborative working across the sectors to enhance the services that are currently available. And the ECC projects will, of course, improve that integration to ensure that the most appropriate care is available in the most appropriate setting for our patients. We have very close links and day-to-day working relationships between the Integrated Care Programme for older people, with the ambulatory teams, the Integrated Care Programme for chronic disease management, the FIT team in our ED department, the reablement team in Listarn, as well as the transitional step-down beds in Listarn, all of which continue to reduce the demands on our acute service, of course, as well as improve patient experience, which, of course, is our ultimate goal. So really positive, looking forward to the future.
Thanks very much, Anne-Marie. And as you said, the patient, of course, is at the centre of this. And we have, I think, the lowest number of people in long-term care across our CH, which, you know, is testament to the work that has been done around supporting those older people to remain living at home. So thank you, Dermot, Tony and Anne-Marie, for your positive words around the programme and the shared vision of improved services for our population living in these areas. I would like to hand over now to Mandy Doyle, who has recently been appointed as Head of Service for Primary Care, to introduce us to the primary care, community healthcare networks and chronic disease management specialist teams. So over to you, Mandy. Thank you.
Thank you, Lynn, and good afternoon all. As we know, the investment in community services under the ECC programme is very welcome and a very much an exciting time for our staff and teams right across CHO1. Currently, CHO1 has 8 community health networks, and as you can see from the slide deck, all our network managers are in post, looking very well on the slide deck and are progressing great work in getting the structures in place, which includes the due diligence process. All of our network managers are on the webinar. These are all most welcome. We also acknowledge that this new model is a significant change in the roles for many of our staff and our teams, and it presents new challenges with that change. So, and I want to take this opportunity to compliment all of our staff and teams that are working across all of the services, including primary care, in how they've embraced this change, and in particular to mention our heads of discipline and our therapy managers. Inishowen Network was one of the 9 national learning sites, and Maura Gillen, who's online, is now going to speak about Inishowen Community Health Network. As a learning site, they're a little bit further on in the implementation phase. As mentioned earlier, we are also setting up chronic disease management hubs across CHO1 in Cavan, Donegal and Sligo, with specialist teams that are providing that care for people who are living with diabetes, cardiac conditions and respiratory conditions. And just to follow on, this involves a process of integration with our colleagues in acute that has already been mentioned, and indeed then across all of our other care groups. All operational leads are in post, and as Dermot has outlined, recruitment is at an advanced stage. The hub in Sligo and Donegal have diagnostics on site, and it's also intended that this will be on site in the future for our Cavan hub. 2 short videos will demonstrate the chronic disease management service recorded on site in our chronic disease management hub in Sligo. So now I'll hand over to Maura, who will give an overview of the community health networks. Thanks.
Thanks, Mandy, for that. Good afternoon, everyone. My name's Maura and I'm the network manager now for Inishowen, and as Mandy has said, it's one of the 9 original learning sites in Ireland. The Community Healthcare Network is recognised now as the single accountable unit of delivery for primary care services and for a defined population in a defined geographical area. So for Inishowen, we have 3 primary care teams spread across a population of approximately 34,000 people, and our network has actually been live since last October. The Community Healthcare Network is different to previous ways of working in that I am now the operational manager for 6 disciplines in primary care in Inishowen. I work closely with the therapy manager who provides the clinicians in the 6 disciplines with their clinical supervision and provide clinical expertise to me as the network manager on the development of pathways of care for the service user in the Inishowen area and across the wider networks across Donegal and the CHO1. As you can see, I'm an operational manager for physiotherapy, occupational therapy, speech and language therapists, social workers, dietitians and podiatrists, and they're all delineated there by the blue coloured clinicians on the screen. Although nursing and GP services are not part of the operational structure, they are closely aligned with and work alongside the GP lead and the ADPHN for us to provide structures and security for the staff within the network. There is a management team structure within the Community Healthcare Network, and its function is to develop the strategic pathways for the population and integration with other specialist services within the ECC model. The network team developed the pathways of care into the ECC structures for ICPOP and chronic disease, and as we've talked about already with the ECC model, we're 3 legs and the 1 stool, where the patients will receive episodic care and then return to their primary care team management within their own community. The Community Healthcare Network Manager will also reach out to other services such as CAMHS, Children with Disabilities Network teams, psychology services, mental health services, health and wellbeing, and wider community supports through their social prescribing initiatives. The purpose of the network is to use the structures of the clinical team meetings to discuss care that is complex and deliver that care in the right place, the right time, by the right person, and at the lowest level of complexity. The single point of entry into primary care will enable the client to access services in a less complex way. Unidisciplinary working will continue for a cohort of those referred into primary care, but the difference now is that the network model supports clinicians in a seamless way to discuss care at a multidisciplinary level and to develop action logs or plans of care in a collaborative way for the service user. We have developed the structures and the processes to date to ensure that the staff are safe within the space of the clinical teams and feel supported in managing the most complex cases of care within their caseload. So I'm now going to take you through a case study and a recent example of a lady who was referred into the system. So the case study relates to a client of approximately 50 years of age, female, presenting with chronic pain conditions, increasing social isolation, self-reported mobility issues, and a growing dependency on the GP services and medical care that's in the area. The GP originally received the referral, sent the referral to the social worker as the patient was self-requesting home support. However, being part of the core clinical team for the network, the social worker was aware of the benefits of the multidisciplinary discussion because the GP is also present at these meetings. This is different to times past, as the process of collating a clinical team meeting is now built into the structures within the network model and is arranged on a monthly basis for each primary care team. The GP then referred this lady's case to me as the network manager as the central point of referral into the clinical team meeting structure. The patient was then scheduled for a discussion at the clinical team meeting. We had a roundtable discussion identifying who was already involved in the person's care and the potential benefits of further referral within the primary care services initially before we started looking outside to the more specialised teams. In this particular case, following our discussion, it was decided that our primary care physio and OT were the most appropriate people to start the care and to start with the initial assessments of her needs. The PHN and the GP were also part of this care conversation. So the action log and care plan referred to those clinicians who would undertake a review and do baseline assessments. The PHN was already involved, and it was recommended that the PHN refer the client to our social prescriber in Inishowen, who is now based in Inishowen and works full-time with the network through health and wellbeing. What we wanted to do there was to encourage social engagement and increase the client's social supports. The team recognised that there was already a high level of medical intervention in this case through the GP practice, and that adding clinicians would increase the dependency on the medical structures and HSE services, which is not in fitting with the shift left model away from medical dependencies, which is the core fundamental piece of Sláinte care. The key worker role is a fundamental part of the model and allows for the service user to be supported in their care journey. In this specific case, the GP had been identified as the key worker, as they were the clinician that was most involved with this client at this time. The key worker role will change over time as the needs of this service user changes. We can monitor if the social prescribing interventions has reduced the dependency on the GP services with the initial supports. On further reviews, we will refer onward to the specialist teams if this is required. By referring from the Community Healthcare Network team and the clinical team structures, we can avoid duplication and manage episodes of care into the specialist teams and back to primary care for onward management where appropriate. The Community Healthcare Network in Inishowen is at an early stage, but we are striving to achieve our target of regular clinical team meetings for each primary care team. To date, all involved have commented on the positive way of working and the support that they have gained in working in a multidisciplinary way with the more complex cases that they are actually managing on their caseload. So with that in mind, I would also like now to introduce you to Kathy Murray, who is our GP lead for Inishowen, to speak about her role as our lead GP in the Inishowen area.
Hi, thanks Maura, and thanks Lynn for the invite to present at the webinar. My name is Kathy Murray. I'm a GP based in Clonmany, and I'm also GP lead for the Inishowen Community Healthcare Network. So Maura has just talked you through the network model, and I'm just going to briefly describe my role as GP lead. So I think as GPs, we're usually the first point of contact for patients accessing health services. And as such, I believe we are in a very good position to understand the health needs of our local population and identify any gaps in the services. I think it's vital that we're involved in the development of the community healthcare networks, and the role of the GP lead has helped to formalise this engagement. As part of my role, I've been liaising both informally and formally with my colleagues through the GP baseline survey and the GP workshop in identifying population needs. Through these engagements, I've gained a better understanding of their frustrations and barriers in accessing primary care services, feeding this back to the network manager and the wider management team at our engagements. One example of this was the referral processes, which were largely paper-based and didn't fit very well with our fully computerised GP practices. We have been working on establishing computerised GP referral pathways, which are based on the generic GP or generic health the generic health mail that we're all very familiar with in general practice, and this has been very well received by the GP community. Another major part of my role is helping GPs to gain a better understanding of the network model and to see the benefits of the structure to their practice and their patients. I've worked with Maura in setting up the clinical team meetings and encouraging GP involvement. I hope that we have helped GPs to see that their engagement in the network will hopefully benefit them in the long run in easing some of the burdens on their services. I look forward to the appointment of GP leads in the other networks in CHO1 and working collaboratively with these appointments to further develop the role of the GP lead. Thank you.
Thank you very much, Kathy. And just to say, we have good kind of interface meetings with GPs across CH, Cavan, Donegal, Leitrim, Monaghan and Sligo, which is hugely beneficial and really important to have GPs at the table. And certainly I feel the frustration around the raft of referral forms, so that's certainly something that we are prioritising with our digital health team to address. So thank you very much, Kathy, and to Maura for the comprehensive overview of the CHNs and Mandy. So there are 3 chronic disease hubs, as Dermot and Mandy both referenced, and all our 3 operation leads are in post and they're on the call today. So welcome to Fiona Gilliland, who's the operational lead in Cavan Hub, Claire McGrory, who's in Letterkenny, and Suzanne Keenan, who's in the Benbulben Hub in Sligo, who has produced the video, which we are going to play now. Thank you.
Welcome to the Benbulben Chronic Disease Management Hub. I provide operational line management to the community-based staff. Clinical management and professional supervision are provided by the relevant heads of discipline. The chronic disease management hubs are central to the national framework for the integrated prevention and management of chronic disease in Ireland. At present, the focus for chronic disease management is cardiovascular disease, respiratory conditions, in particular asthma, chronic obstructive pulmonary disease, also known as COPD, and diabetes. There are 3 specialist teams of clinical staff dedicated to these diseases in the community. The Benbulben Hub supports individuals from South Donegal, Sligo, Leitrim and West Cavan. 2 additional hubs are being established in Letterkenny to support people from Donegal and Cavan to support people from Cavan, Monaghan. I would now like to introduce you to some of our team members.
I coordinate the pulmonary rehab programme for Sligo Leitrim.
I provide admin support to the pulmonary rehab and the Deadspin team, making sure that the nurse, physios and dietitians have everything they need to run the programme.
I support the dietary needs of people with type 2 diabetes.
Cardiac Diagnostics in the community setting provides comprehensive echo reports.
I'm the respiratory physiologist. I'm employed by Sligo University Hospital to cover the acute respiratory lung function testing service.
In the podiatry department, we work as part of a foot protection team.
I am a nurse as part of the pulmonary rehab team.
My main role is supporting people with diabetes, both in the hospital, but also outside of the hospital in primary care settings, supporting general practice and community.
I'm a community heart failure nurse and I run 6 community clinics, including Ballyshannon and Enniscrone.
All of the teams and members of the public are supported with input from Health and Wellbeing, including the Living Well programme, smoke cessation and making every contact count. The development of the Benbulben Hub is a positive and welcome development in the region. It will support people with chronic disease to access services at the right time, in the right place and from the right person.
My name is Lee Baker. I'm the respiratory physiologist. This is our clinical blood gauge machine for our respiratory Sligo University Hospital respiratory clinics. But for lung function, the ability to use a portable hemoglobin concentrator and analyzer is really necessary, especially for lung diffusion, as it adjusts lung diffusion. We have some safety equipment here in case a patient feels unwell. We have computer access to the hospital system. And then we also have a spirometry machine with ventilation for both bacterial and viral filtration and for air filtration, which is very important. And we've got a patient chair with arms. Once again, when you're doing spirometry, it's important that the patient is safe, as they can feel a little bit unwell, especially at the end of a spirometry. So I'm going to take you next door. We also have here in the corner a water cooler, because cough is highly associated and some patients are unable to continue testing without water. This is our main spirometry room where we can do both spirometry and full lung function testing. Spirometry, often for approximately 70% of patients, would lead on to full lung function testing, and you need this type of equipment in order to do lung diffusion testing and lung volume testing. Lung diffusion is to estimate whether there's been any impairment in the alveoli, and lung volumes is to see whether there is any hyperinflation, which is common in emphysema type patients. I have access to my gases here in the corner, and I would also normally have oxygen, but as I have it currently outside, I don't need it, but you do need something to support the gases. Once again, I have air filtration and bacterial viral filter, and all of the equipment is cleaned down after each patient.
Thank you. I'd just like to ask Suzanne Keenan, the operational lead in Sligo, just to say a few words. Thank you.
Great, thank you. Thanks very much, Lynn. As Lynn has already said, the three leads for chronic disease are all in post, and just our contact details are actually in the back of the ECC our first newsletter, as are the contact details for all the network managers. And I suppose currently we're working on establishing our chronic disease implementation groups in respiratory, cardiology and diabetes, and our subgroups, and we're also working on how we can involve our service users in a meaningful way on those groups. Some of our teams as well require GP representation. So if you are a GP and you have a particular interest in a chronic disease, please get in contact with one of the leads in your area. We'd really appreciate your involvement. We're also working closely with SAILTA and the RCSI and HR to establish teams. So recruitment is ongoing. Again, if you're on the webinar and you have a particular interest in any of the chronic disease hubs and working as part of the team, please contact the lead in your area because it would be great to hear from you. I suppose in terms of digital, a new digital health team has been established in the region, and we're working very closely with them to streamline our pathways, particularly the referral process, so that the hubs are going to have access to consistent digital systems that will allow us to work effectively with the community and with CELTA. So I suppose that's where we're at the moment. Thanks very much.
Thanks very much, Suzanne, and thank you to yourself and the team there in Sligo. I think the videos they say a lot. Sometimes a picture says a lot more than words. So thank you to all the team there, and certainly those are videos that we will be sharing the links with, so people can view them and share them with their colleagues. So thank you very much, Suzanne and Lee, for that. Great developments really across the area in a short space of time, but lots still to do, but certainly good progress so far. Unfortunately, Frank Morrison, Head of Services for Older Persons, is on leave this week and unable to join us today. So on his behalf, I'm just going to introduce the Integrated Care Programme piece for older people. So like the chronic disease hubs, there's 3 ambulatory hubs that have been established in our area. Sligo started as a national demonstrator site in 2015-16, and actually that project started in Sligo University Hospital with a specialist geriatric ward, and Joe Short would have been involved in that, and Maura Heffernan. Cavan and Donegal are in the earlier stages, and they're providing both falls and reablement services for older people. And as Anne-Marie Campbell outlined earlier, great work has been done by Rose Mooney and herself with Listarn, the step down unit there. So great work there. Louise Carlin is the operation lead in the Cavan Monaghan area and is on the call, so welcome to Louise. Maura Heffernan was the operational lead in Sligo. However, CELTA got her back as Director of Nursing in Sligo University Hospital. So we look forward to continued working with Maura in her new role. So now I would like to hand you over and introduce Melissa Currid, who's the operational lead for ICPOP in Donegal, but she's taken up that post in Sligo. And so the post in Sligo has been advertised and in Donegal, sorry, has been advertised and will be interviewed soon. So Melissa's going to give us an overview of the ICPOP programme across the area and talk us through those developments. So over to you, Melissa. Thank you.
Thank you, Lynn. The focus of Integrated Care Programme for older people is shifting the model of care away from the acute hospital setting by providing specialist care in the community for older people. And the aim of the service is to optimise independence and functioning, prevent hospital admission and reduce length of stay, and also develop clear pathways for older people who may have complex health and social care needs, and thus enable them to stay at home or return home quicker with the support of coordinated and integrated care. Key work has concentrated in improving pathways in the areas of frailty, falls and dementia care. Recognising and screening for frailty and completion of a comprehensive geriatric assessment is a priority. Integrated care teams are established, as Lynn mentioned, in each of the counties in CHO1. These are multidisciplinary integrated care teams, which will include consultant geriatrician on each team. Linking with frailty at the front door teams in each of the acute hospitals, community health networks, collaboration with voluntary and other services, and providing a reablement service to identify patients are also priorities. Integrated falls prevention teams are established in each area with services such as falls prevention clinics in multiple sites and domiciliary assessment provided. Physiotherapy-led strength and balance classes, falls prevention and bone health education to groups such as day centres, and also the maintenance of a falls database are being rolled out. In the area of dementia care, recruitment of a memory and assessment support service is underway for each county, which will consist of a multidisciplinary team and will include a consultant psychiatrist of old age. Other priorities include developing delirium screening and pathways, education and awareness training for carers and home support workers in collaboration with the National Dementia Office, and establishing complex cognitive cases multidisciplinary team meetings in all areas. You will see on the slide some examples of outcomes our teams have achieved to date. Ambulatory hubs are now established, as Lynn mentioned, in Cavan, Donegal and Sligo Leitrim, where all of the integrated care teams will be based. And it is planned going forward that a single point of entry for referrals will be established. We provide comprehensive geriatric assessment and a short-term programme of support for up to 6 to 8 weeks duration, multifactorial falls risk assessment and interventions as required, but most importantly, timely access to specialist services for older people. The integrated care for older persons focus is on older people who are at risk of hospital admission or suitable for supported early discharge. They may be complex clients who no longer are coping at home due to increasing frailty or illness. They may require a case management approach, are at risk of falls, have reduced mobility or fear of falling and require intervention. And they may be in need of signposting to other services. A key element in addressing frailty is adopting a reablement approach. Across CHO1, a reablement service is provided with a designated reablement team in Sligo Leitrim, providing support to clients in their own home environment following acute illness or injury, which has impacted on their ability to function independently. Clients accepted on this programme must have identified reablement functional goals and the potential to achieve these goals within the period of up to 6 weeks. You will see on this slide some of the positive feedback that our teams have received to date, and I feel clearly demonstrates the benefits of the services provided. Thank you.
Thank you very much, Melissa. So that demonstrates the great work that has been done across the programme there, and great to see such positive outcomes achieved for our older population. I know the consultant geriatricians have been critical to progressing the model, and certainly having Professor Drum or Dr. Drum and Dr. O'Sullivan rotate to the community in Sligo Leitrim has been of great benefit to developing the service for our service users, and we certainly look forward to the recruitment of community consultant geriatricians in Donegal and Cavan, and hopefully that will be in the near future. Okay, so we've now covered our areas of focus today, and I think we're doing okay on time as well. So thank you to everybody for staying with us. So we've covered the ECC governance structure, and we had an introduction from Dermot Monaghan, Chief Officer, and Tony Canavan, CEO in the Sailta Group, and also Anne-Marie from Cavan General and Cavan and Monaghan Hospitals. We've had an overview of the community healthcare networks, our chronic disease specialist teams, and the integrated care for older persons. We are now moving towards the question and answer section. So if anybody has any questions, please feel free to add them to the chat box, and we'll certainly aim to address all of those. I'm conscious that we've now been sitting for, I think, 35 minutes. So if everyone would like to stand up and shake your arms and legs about, so to get that energy going again and generate some good questions. And if you're feeling self-conscious, just a reminder that your cameras are turned off, apart from our panelists. So I understand some people may have to leave, but please be assured that an FAQ document will be prepared and circulated following this webinar. So if you just give us a wee minute, we're just going to have a wee look at the questions, and we'll come back to you in just a minute. Thank you. Okay, thank you for your patience there. So there's just a couple of questions really have come in. So just one question in here. As a member of the public, how could I get a referral to spirometry service for assessment of asthma? So I wonder if Lee or Suzanne would mind taking that question. Thank you.
Hi, I'll answer that if you like. So you can still refer in for direct GP service for Sligo anyway, into Sligo University Hospital, just like you would request a respiratory consultant referral. And if you just put on the top of it, request for lung function, it will come down to my office, and I can assess it and either complete it at the hospital or down in the chronic disease management hub, whichever is most suitable for the patient.
That's great. Thank you very much, Lee, for that. Another question here. Do networks only relate to primary care service users, or can any service users with disabilities like ID, ASD, mental health use the services? So maybe Maura, would you mind taking that one? Thank you.
Good afternoon. The fundamental principle is that it's population health is the way that we are working. So we are working closely with those within ID services and within the chronic disease, with the Children with Disabilities Network. There is work ongoing at the minute around the different thresholds to meet different services. So we have to establish those pathways yet, but our clinical team meetings would be a forum to allow people to have their care discussed and maybe a direction of travel and where is the most appropriate place for that care to be managed. At the very outset, that's the initial plans anyway. So I say we're early stages. We are in the process of integrating a lot of those care interfaces and trying to establish the most seamless pathway through for the patient. I hope that answers your question, does it?
That's great, Maura, thank you. And another one for you now that you're in the hot seat there. You spoke about clinical meetings once per month where patients were discussed. Is there a plan to have them more frequently, perhaps, as to avoid potential for admission to hospital? Thank you.
Yes, we've set them up initially as once per month, and we will see how the demand for the clinical team meetings transpire. What we are trying to do in the initial stages is sort of set them at a 1 hour once a month to have a discussion about our patients. But if somebody is in need of urgent care and interventions, that can actually be dealt with in the normal way, which is where you would go through to your public health nurse and to your GP services to actually support you to avoid admission in the first instance, and then at a wider multidisciplinary level you would have your care then discussed. But having your care discussed does actually require the consent of the person who is being discussed, so that we don't cause problems with GDPR and that we don't have issues with people having their care discussed when they don't know about it as well. So it's a more controlled process, but the multidisciplinary care is available there.
That's great, Maura, thank you. So at the moment, that appears to be all our questions for now. So I'd just like to say on behalf of the wider ECC Programme Office to thank you all for attending our webinar today. As I said at the start of this session, we will be hosting other webinars in relation to ECC, and we would welcome your feedback on what subjects or topics you would like covered. Orla is just launching a WebEx poll there, so you'll see that in the webinar window, and we just ask that you would take a wee minute maybe to complete that. And just a reminder that our webinar today is recorded. I just want to ask, does Tony or Dermot wish to say anything before we finish off for this afternoon?
No, just to say, Lynn, can you hear me?
Yes.
Yeah,
yes,
just to
thanks,
say thanks for everybody for pulling it together, and for the people who have taken time out of their busy day to attend. And as you've said rightly there, this is the start of a journey, and there will be more of these events planned, and particularly with you know, the general public and our GP colleagues in mind as well, being able to sort of provide them with this level of information as well. So it'll be very, very positive for them to hear this as well. And that'll be just again to reiterate, to thank everybody for the hard work they've done and for the contribution they've given to our services through COVID as well, and to really acknowledge that.
Thank you for that, Dermot. I don't know if Tony is still on, if he wants to say anything.
Only very simply to add my thanks to those already expressed by Dermot, to everybody that's been involved. Thank you.
That's great. Thank you very much, Tony. There's just one question here. Can the client attend their care discussion remotely if wished? So I just ask you, Maura, for that.
Can answer that if you want. Yes, they would be invited to attend
yes,
if they were.
Yeah.
That's great, Kathy. Thanks very much for that. So yeah, just so as I say, thanks to everybody, and thanks to everybody who presented today. And this was kind of representing the wider, you know, services out there. So there will be an opportunity for others that didn't present today on future webinars. So just to say thank you very much. Have a great afternoon, and goodbye from myself. And just to say thank you to Orla Gilchrist in my office who put a lot of work into planning today as well. So thank you very much, and bye for now.